The purpose of the Hawkins-Kennedy test is to test for subacromial impingement. It can be carried out with the patient seated or standing. I'm going to place my patient's arm into 90 degrees of shoulder flexion and 90 degrees of elbow flexion. I'm then going to passively internally rotate the patient's arm. A positive test would be replication of my patient's symptoms, which would be pain. Do you feel any pain?
No.
So this would be a negative test. The clinical reasoning behind this is that by placing the patient into 90 degrees of shoulder flexion combined with internal rotation, this decreases the space between the humeral head and the inferior side of the acromion process. As this space is narrowed, it causes the structures within the space to become compressed, thus causing a pain response. The Hawkins-Kennedy test presents with a 79% sensitivity and a 59% specificity, being scored the highest out of all impingement tests. Research suggests that the use of one special test to test for shoulder impingement is greatly unreliable. It is suggested that a combination of 3 special tests such as the Hawkins-Kennedy, NIS and painful arc sign will increase diagnostic accuracy for a shoulder impingement. There is further research to suggest that poor reliability may be a factor for lack of diagnostic accuracy of clinical tests. Many studies that have previously investigated that diagnostic accuracy of impingement tests have collated poor results due to the lack of anatomical validity. According to Khan et al. 2013, he suggested that although the diagnosis of a shoulder impingement remains clinical, technology advancements suggest that a gold standard way of identifying and diagnosing a shoulder impingement is via the use of ultrasound scanning. Not only is it reliable, but also cost effective.